Hello, and welcome to part 2 of our webcast, Metabolic Matters, MASLD in Obesity, Early Detection and Management. I'm your moderator, Rachel Deer. Please note a portion of this webcast was recorded at Obesity Week in Atlanta, Georgia on November 4th, 2025. If you haven't watched part 1 yet, we strongly encourage you to do so. And here are our faculty: Dr. Jamie Almondoz, Medical Director of the Weight Wellness Program and Professor of Medicine in the Division of Endocrinology at UT Southwestern, and Dr. Lee Kaplan, Director of the Obesity and Metabolism Institute in Boston and Professor of Medicine at the Geisel School of Medicine at Dartmouth. Here are our faculty disclosures. This activity is supported by an independent medical educational grant from Boehringer Ingelheim Pharmaceuticals. All activity content and materials have been developed solely by the planning committee members and faculty presenters. Here are our learning objectives. Identify and articulate the pathophysiologic mechanisms that underlie the development and progression of MASLD, and critically appraise and synthesize safety and efficacy findings from recent clinical trials of dual GLP-1 glucagon receptor agonists for MASH treatment. I'll now turn it over to Dr. Almondoz.
So to recap what was presented in part 1, we're going to start with the definition of MASLD, which is defined as hepatic steatosis with at least one trait of the metabolic syndrome, and that can include markers of adiposity or indirect measures of adiposity such as elevated body mass index, increased waist circumference as a more effective measure of visceral or ectopic adiposity, hyperglycemia with elevated fasting glucose, hemoglobin A1C, or diagnosis of type 2 diabetes, elevated blood pressure, elevated triglyceride levels, or low HDL levels. MASLD is part of a broader disease of our classification of steatotic liver disease, and MASLD can, of course, progress to MASH, which we're going to discuss in greater detail. Prior to this, alcohol-associated liver disease, or ALD, had been one of the most common causes of steatotic liver disease. Of course, MASLD and ALD can coexist, and there's also a spectrum of what we called MET-ALD, which is the combination of MASLD and alcohol-associated liver disease. Depending on the consumption of alcohol, you can determine whether something is more MASLD predominant or ALD predominant. In addition, there are a variety of other etiologies, including drug-induced liver injury, rarer genetic causes of steatotic liver disease, and of course cryptogenic steatotic liver disease, where the etiology is undetermined. The prevalence of MASLD is much, much higher than people think. So amongst adults living within the US, it's thought that about 3 out of every 10 adults is living with MASLD. Rates appear to be much higher throughout South America and indeed through North Africa and the Middle Eastern regions. What's interesting to note is that amongst Asia, where rates of obesity tend to be lower, there still is quite a high prevalence of MASLD, speaking to the metabolic component of this beyond the way in which we process excess nutrients and adiposity within the body. There can be inflammation that occurs within the liver at lower levels of adiposity. When we look at the overall prevalence of MASLD, it's thought to be, again, about 1/3 of adults living in the US, but it's projected that by 2050, this will increase to about 40% of US adults, and that the prevalence of MASH is going to increase from about 6% to around 8%. And while those numbers don't sound very large, when we look at the proportion of people in terms of the population, it's estimated that more than 120 million adults will have MASLD and more than 20 million will have MASH. One of the main clinical challenges is that MASLD is highly underrecognized and underdiagnosed, largely because it can be relatively asymptomatic or the symptoms may be very vague. Also, MASLD may not be apparent on clinical examination or on routine lab testing. It's thought that about 75% of people living with obesity also have MASLD, and about a third of people with obesity have MASH. Those with obesity have a 5 times higher risk of developing MASLD and are more than twice as likely to have what we call at-risk MASH than those with a healthy level of BMI. There are a variety of contributors to MASLD, and these can include lifestyle and dietary factors such as higher consumptions of fructose, saturated, and trans fats. Also, increased alcohol intake can increase liver steatosis, in addition to certain drugs and environmental toxins. In addition, increased adiposity and insulin resistance syndromes and type 2 diabetes can increase risk of MASLD, in addition to some metabolic conditions such as uncontrolled primary hypothyroidism. There are, of course, genetic predispositions, including genetic variants such as PNPLA3, and also epigenetic and microbiome factors within the body. There are protective factors for MASLD, including female sex and estrogen, but this speaks to the evolution of the disease or changing risk throughout the life course as hormone levels change. The progression of MASLD looks like this, where there is development of steatosis, which can then progress to cell inflammation, injury, and fibrosis, which is MASH, which can then present as cirrhosis, which can either be compensated cirrhosis, cirrhosis with portal hypertension, or decompensated cirrhosis. One of the complications that we need to screen for and be aware of for this is hepatocellular carcinoma, but it's important to note that even though it is more common amongst people with cirrhosis, it can occur at any stage of the MASH cycle. When we classify progression of fibrosis of MASH, we can start with F0, which is MASH with no fibrosis, and this is then can transition to F1, which is mild fibrosis, F2, which is significant, F3, which is advanced, and F4 MASH, which is cirrhosis. The F2 and F3 are considered to be at-risk MASH, which was a term that I used earlier on in the recap. When we look at the time it takes to go from a level of fibrosis to cirrhosis or F4, you can see this varies by severity of the fibrosis stage. And so those with F1, it can take around 3 decades, those with F2, about 2 decades, and those with F3, it can be as little as 5 to 6 years. We know that fibrosis is one of the strongest factors in influencing the progression of MASLD, but it's important to note that nearly 20% of people with MASH can be rapid progressors and can progress to cirrhosis in as little as 5 years. When we look at the impact of MASLD on age-standardized mortality rates, we can see that there are certain demographics that can influence risk among certain groups. So we see here that mortality is greater amongst those aged 65 or greater in the figure on the left. And in the figure on the right, we can see those in the Hispanic and non-Hispanic white groups have greater age standardized mortality rates compared to non-Hispanic Asians and non-Hispanic Black populations within the US. It's important to note as we talk about mortality that even though MASLD was thought to be solely a liver condition, it's really a systemic disease. And I think this is nicely illustrated in this figure here that demonstrates that people are more likely to die of cardiovascular disease than a liver-specific complication. And they're also more likely to have extrahepatic cancers. And so this highlights the need for cardiovascular risk reduction amongst people living with MASLD, but also appropriate cancer screening in this population too. We've highlighted that MASLD is a systemic disease and not just limited to the liver. And what this shows here is the wide-reaching implications for cardiometabolic and overall health for people living within MASLD, as they are more likely to have chronic kidney disease, cardiovascular conditions including atrial fibrillation, heart failure, and also metabolic conditions like type 2 diabetes. And as highlighted before, there's also a higher prevalence of extrahepatic cancers that should also be screened for. When we talk about the association between MASLD and cardiovascular disease, I think diagrams like this really nicely illustrate the parallels that occur with the two conditions, where there is excess accumulation of lipid here within the liver and also within the wall of the blood vessels. There's then inflammation, such as steatohepatitis or MASH, can then progress to fibrosis or plaque formation, with then advanced disease where there can be problems within the plaque, within the blood vessels, including plaque rupture and fissuring that leads to thrombosis and end organ damage, but also within the liver, the fibrosis leading to end organ damage or cirrhosis too. It's important to highlight that the severity of fibrosis can also predict decompensation within the liver. And what we see here stratified by fibrosis stage, showing here that those with the F4, which is the darkest line at the top here, have higher rates of hepatic decompensation relative to those with no fibrosis or with lower levels of fibrosis. This is also seen in this all-cause mortality figure here, showing higher probability of mortality amongst those with advanced fibrosis relative to those with no fibrosis. This means that it's important for us to evaluate MASH and to determine severity so that we can intervene when the disease is modifiable. The question remains, who should we evaluate? What are the appropriate clinical markers of severity of fibrosis? How can we, in a non-invasive way, without doing or resorting to liver biopsy, estimate the severity of fibrosis, choose appropriate treatments, and of course know when to refer to our colleagues in hepatology, or do these patients need liver biopsy for more definitive diagnosis? So who should be screened? It's recommended that those who have type 2 diabetes, those living with obesity and other metabolic disorders, and also those who have incidental findings of hepatic steatosis by imaging, or those who may have concerning lab tests or findings where you may be concerned based on the clinical picture for MASLD and MASH. There are important ways to note how we should not be screening for MASH in an evidence-based way. Just screening purely on liver enzymes is too insensitive, and it's important to note that around half of people with MASLD have normal liver tests. And so just checking liver tests and saying, well, they're normal, my patient does not have MASH, is not a very good approach for this. Ultrasound is a way that often picks up previously unrecognized MASLD and MASH, but it's really not that sensitive for liver fat, and it's not quantitative either. And it also does not provide information about inflammation or liver cell injury or fibrosis. What we need to do is make sure that we're assessing the degree of fibrosis so that we can identify those who are at high risk, as evidenced in the prior images showing the relationship between stage of fibrosis, adverse liver outcomes, and mortality. So when we look at screening tools, FIB4 is a popular, very easy and accessible way to screen for MASH, fibrosis. And so what we can do is look at the different factors that go into this equation, including age, AST and ALT, and the platelet count. So what we need are simple information about the patient, like the age, a CMP or comprehensive metabolic panel or liver tests that often include the AST and ALT, and a CBC for the platelet count. Once we calculate the FIB4, we then need to interpret, well, what does this mean? So a FIB4 of less than 1.3 is considered low risk, and the recommendation is that we then repeat it in about 2 years. For those who have a FIB4 score of 1.3 to 2.67, this is considered intermediate or indeterminate risk, and it's recommended that they undergo additional screening with what's called VCTE, or vibration-controlled transient elastography. For those with a FIB4 score of 2.67 or greater, this is considered to be high risk, and we should then treat MASH if present in these patients, or refer to our hepatology colleagues if we are not sure what to do as a next step. It's important to know that FIB4 is an easy calculation to do in most electronic health record systems, and we can do, for example, in my electronic health record system, we just type in .fib4 and the calculation will automatically appear within our notes. Vibration-controlled transient elastography, or VCTE, which includes common measures such as FibroScan, is a way to get a measurement of liver stiffness to estimate the severity of liver fibrosis in a non-invasive way. When we look at the FIB-4 score and see that somebody has indeterminate risk, it's recommended that the next step of the evaluation is to perform VCTE. When we look at the results, we'll see something that measures liver stiffness, and it's often represented in kilopascal measurements. For those with less than 8 kilopascals, there's a low risk of advanced fibrosis, and it's recommended to repeat the VCTE in about 2 years. For those with 8 to 12, that's intermediate risk of advanced fibrosis, and it's recommended to treat MASH. And for those with greater than 12 kilopascals, there's a high risk of advanced fibrosis, and it's recommended to refer to hepatology and to consider treatment if appropriate. So with that, that ends the recap, and what we're going to do now is move on to Dr. Lee Kaplan's presentation at Obesity Week 2025 about how MASH is treated.
All right, let's continue. So the treatment options for MASH are quite similar to the treatment options for obesity, but not identical. There's lifestyle-based treatment, a healthy diet, more than a calorie-restricted diet, regular physical activity, because the benefits of a healthy diet and the benefits of regular physical activity on the complications of diabetes are well established, whether it be MASH or it be diabetes or heart disease, even cancer. What is less clear is whether those improvements in those complications of obesity work by treating the obesity. And therefore, we just don't know the degree to which lifestyle-based treatment is going to be effective in the long term. We have medications. I'll talk about those in a second. One of them is resmetirom. Resmetirom is the first drug that was approved in 2024 for the treatment of MASH. There are older drugs, most notably pioglitazone, which is a thiazolidinedione, which has been shown to have some benefit, significant benefit, but has not been approved by the FDA. There's vitamin E. Vitamin E has also been shown to have some benefit, but vitamin E at high doses is toxic to the liver, and so you have to. So the therapeutic index is not as good as we would like, and as a result, most hepatologists, not all, but most hepatologists have stopped using vitamin E. The drugs that are listed here, resmetirom and semaglutide. Semaglutide in August of this year was approved for the treatment of MASH. The treatment that is approved for is advanced or advancing or at-risk MASH, which means F1, F2, and F3. The studies primarily look at F2 and F3, and in the case of semaglutide, it's F2 where we have the most definitive data. Why is that the case? This gets a little bit into the weeds, but the part one of the ESSENCE trial that supported the approval of semaglutide only looked at the decrease in fibrosis for the F2 subgroup. That was a planned look. It wasn't retrospective. It was a planned look that the F2 subgroup would have an interim analysis, and that came back positive for improving fibrosis. F3 is not going to be evaluated until the trial is complete, part two of the trial. Part one is 72 weeks. Part two is 240 weeks. So we still got 170 weeks or so to go. So which is 3 years. So just understand that gets a little bit into the weeds, but for those of you who are paying attention to those weeds, it's important to recognize that we're really talking about F2 and F3 primarily. There are studies ongoing for treating F4, and F4, as Jamie said, is divided. Cirrhosis is divided into compensated cirrhosis, which is cirrhosis without portal hypertensive complications. Second group is cirrhosis with portal hypertension, and the third group is cirrhosis that is decompensated and not only has portal hypertension, but basically is heading toward end-stage liver disease and liver failure. Once you get beyond compensated cirrhosis, it's obligatory to refer to a hepatologist, and most people would even argue to refer compensated cirrhosis to the hepatologist. But once you get beyond that, it's absolutely necessary. The patient is getting close, as you've already seen from Jamie's talk, is getting close to decompensation. Of course, we have the ability to treat this disease effectively with metabolic bariatric surgery, and even before we had the drugs, metabolic and bariatric surgery was the most effective way to do that, and that doesn't change today just because we have the drugs. And trying to decide amongst the two medications and metabolic and bariatric surgery is really dependent upon the rest of the patient's disease of obesity, the severity of the obesity, the severity of the complications. Jamie, how would you choose amongst those three possibilities for this patient that we've seen today?
In my practice, many of my patients who come have already tried lifestyle modification. So to reinforce that, I think is helpful, but it shouldn't be the destination of care or treatment. I think, unfortunately, access drives a lot of care decisions at the moment. And some patients may have bariatric surgery access where they may not have medication access. With widening indications and other pathways, I'm hopeful that we'll be able to get the right treatment to the right patients, but I would use shared decision-making to kind of work out what the patient is most interested in doing beyond lifestyle intervention alone and what they have access to, because it's important to get them effective treatment.
If the patient had elastography that suggested, let's say, 14, so above 12, but they're heading, where would you go?
So,
and you had the same issues that you're talking about. You have access issues, and et cetera, et cetera. How would you approach a patient like that?
What's the BMI? And I ask that because that determines access to bariatric care and others. I say that as a leading question because there are data with regards to people with compensated cirrhosis doing well after bariatric surgery and decreasing risk of major adverse liver outcomes. So I think we really shouldn't write off bariatric surgery as a treatment, given that so many people, including Medicare beneficiaries, have access to surgery in the U.S.
Yeah, so this patient at this point has a BMI, is a class 2 obesity.
And so with class 2 obesity, they do meet criteria for bariatric surgery. So I would have that discussion, but I think we all know that bariatric volumes are down and we need to respect patient autonomy and shared decision-making. And so while that may be something that they have access to and that data would support the use of, that may not be what they want to do. And it's important to make sure that they partner in the decision.
And with respect to resmetirom and semaglutide, how would you navigate that issue?
I would look more globally with regards to cardiometabolic risk and what data are available with regards to that. As I shared, many of the patients who I see, and this patient has class 2 obesity, are interested in looking at weight reduction in an evidence-based way to improve their health and quality of life, and semaglutide would have definitely the data for that over resmetirom.
Yeah. So if you ask the question, agree with you completely, if you ask the question, do you want your improved liver function with or without weight loss, many of our patients would answer the question in the obvious way. I should mention, though, that resmetirom is a pill. It's not an injectable drug. I should also mention that it's 4 times as expensive as semaglutide. I should also mention that, so one goes one way, one goes the other way. I should also mention that it requires prior authorization. The prior authorization, if you meet the criteria, is automatic, so that there isn't this appeals process typically. So even though it's more expensive, it is far easier for a provider to get a patient on the drug. So none of that tells you the answer, right? It's oral. That makes it maybe easier for some patients. It is more expensive. That makes it more expensive for the healthcare system, but it is easier to get. So think about all those things, and I think that, and it's covered by Medicare if the indications are there. So all of those things make it less of a slam dunk, we're going to use semaglutide when you get to the real world. Okay, let's continue. So continuing with our patient, remind you that she's 46 years old now. She class 2 obesity with BMI of 38. She was referred by her primary care provider for evaluation and treatment of the obesity, but we're focusing on the MASH. She notes now, this is today, 2025, that her weight when not pregnant exceeded 200 pounds for the first time at the age of 40, so that was 6 years ago. She's continued to gain weight steadily over time despite 3 serious attempts to lose weight, resulting in transient weight loss of up to 25 pounds, but it was transient. She always gained the weight back. She continues to drink alcohol socially on the weekends, averaging approximately 2 to 3 drinks per week by her report. So here's our next question for you. This patient is presenting to you for the first time now, age 46, with the history that we've just described, and a referral from her PCP to evaluate and treat the obesity. What would be your next step in the diagnosis or management of her liver disease? Recommend that she stop all alcohol treatment and repeat the tests in 3 months. Calculate a FIB-4 score. Arrange for liver elastography. Refer to a hepatologist for liver biopsy and further treatment. Treat the MASH empirically with resmetirom. Treat the MASH and obesity empirically with semaglutide. So I'm going to ask Jamie to answer first. What would you do here?
Yeah. I like this because there are a lot of options, and I think it's a great discussion point. I think the alcohol component is something that's there, which kind of harkens on to kind of what is the optimal lifestyle as a foundation. I think it's too easy to blame alcohol consumption for abnormal liver transaminases in patients who come in. But when we kind of acknowledge that, given that she has class 2 obesity, her likelihood of having significant steatosis is high, and 1 in 3 patients with this BMI will have MASH. So the pretest probability is there. So to simply write it off, I think this is a yes-and situation where it's part of integrated lifestyle. I think many of us would recommend, if not moderation, cessation of alcohol as part of it, but then calculating kind of risk, knowing that we've had some kind of ups and downs in the patient case with regards to limitations for applicability, and then also then working out treatment for the MASH.
Would you get a elastography?
I would.
You would. Okay. Yeah, my response would be identical. I think more and more hepatologists would be assessing the degree of alcohol intake. So phosphatidylethanol is or PEth, P-E-T-H, is being used more and more by hepatologists to assess. Think of PEth as the hemoglobin A1C of alcohol consumption. It gives you a sense of alcohol consumption, integrated alcohol consumption or total alcohol consumption over the course of about 2 months. So it is a way, you're not doing that to test or to see if the patient's lying to you. You're doing it because just like food recall is not necessarily as accurate as people would like it to be, alcohol recall is not. Yeah, I had a bunch of drinks on the weekend, but how do I average that over the course of time? So PEth is actually a fairly reliable way of looking at alcohol use. Now, the question is, what are you going to do with that information? So right now, it's not widely available. It is commonly used by hepatologists, but not widely available across all practices. But increasingly, I think that as we see perhaps a little bit of a differentiation between the approach we take with MASLD or alcoholic liver disease or versus MASH, I think that we may be seeing this test being used more commonly. Coming back to this case, though, where we don't have that information, I think that we would, I would agree completely with what Jamie said, is I would probably want to get an assessment with the elastography, but I would certainly be on my way to treatment at this point. If I saw that the elastography, if I had the old data, which we didn't have, we talked about possibly getting an elastography 8 years ago, but if I had the old data and I saw a substantial increase in the stiffness, I would probably have a very low threshold to refer to a hepatologist. But the main reason for the elastography at this stage, if I've never done it before, is to set a baseline so that when we treat, we have something to follow. And it's important to have something to follow because really the patient doesn't want a liver biopsy, and you probably don't want to be getting into the middle of a liver biopsy. That's been one of the barriers to treating and evaluating MASH to this point. And now that we've gotten past that barrier, we shouldn't try to restart it. Okay, We're coming to the last part of this. This is the end of the case, and I just want to talk about MASH treatments broadly. So you've already heard from Jamie that what the progression is, and that we go from a healthy liver to steatosis. It's not clear how common you can start with steatosis and then go to MASH. But it's very clear that once you have MASH, you will logically progress to fibrosis and eventually cirrhosis if you live long enough to do that. And cirrhosis will eventually progress to portal hypertension and hepatic decompensation. So where do we want to intervene in this process? And what kinds of intervention do we have? So it turns out that if we improve metabolic function with drugs like resmetirom, which is a thyroid hormone beta receptor, or thyroid hormone receptor beta agonist, it specifically activates mitochondrial function in the liver, and one of the effects of that is to improve liver steatosis, but in the process it also improves liver cell damage, improves inflammation, and it improves fibrosis. So semaglutide does the same thing through a different mechanism. Obviously, you know, GLP-1 indirectly. There are no GLP-1 receptors in the liver, but indirectly it causes mobilization of liver fat, decreased inflammation, improvement in hepatic cell injury. And so even though the focus is on what we would consider the first step here, it has improvement where all of those red arrows are to block all of those steps in the progression of MASLD. Now, in addition, there's work to be done that focuses specifically on decreasing inflammation. And when you decrease inflammation and liver cell injury by medications, none of which are yet at the stage of approval by the FDA, but it turns out that once you do that, you also improve fibrosis, so you improve it at 2 steps. And then there are drugs, again, not yet ready for evaluation and approval by the FDA, that specifically go after the fibrosis. So in the future, we'll be seeing a different array. But I think the surprising thing to many of us was the fact that you see so many effects of these metabolic re-regulators, if you will. And so we didn't think 10 years ago that we would get as much benefit on fibrosis or even on inflammation as we've seen empirically through the clinical trials. And so now we know that it may be that our major focus for treatment going forward will be less on fibrosis, even though fibrosis is the most important thing, because intervening earlier. Now the question is, when do you intervene? Do you intervene at the earliest stage or at a later stage? The later you intervene, the fewer numbers needed to treat to get an effect. The earlier you intervene, the greater likelihood that you will see a benefit for the patient over the long term, but the cost effectiveness may not be there. So we don't really know the answer to that question. Jamie, you want to comment about where your view on when we should be intervening?
Again, I think we adopt too much of kind of a treatment approach once the toothpaste has left the tube, and I think there's a combination of patients presenting late, appropriate screening not being done as kind of part of evidence-based screening and guideline-based screening. So I think there's lots of opportunities for us to intervene across multiple points. I'm a proponent of intervening earlier in the disease of obesity so that we don't wait for complications, but I think there's such limitations on access that ultimately sometimes patients need to develop complications that puts them at risk for adverse long-term health outcomes before they can get access to care, or before something is triggered within a health system that allows them to get advanced risk stratification, that gets them to a clinician who can provide them with the care. So I think we need to take a few steps back with regards to how can we prevent people developing obesity-related complications and treat early to avoid them developing, rather than work out at what point in the complication do I treat.
And I completely agree, and I would remind everybody that the biggest concern here is going to be cardiovascular. So if somebody has or is developing cardiovascular complications, the need to treat aggressively goes up that much more. So the goals of treatment and assessment of efficacy. So again, our goals of treatment are to decrease the major adverse liver outcomes, which are called MALO, it's the equivalent of MACE for the liver, and major adverse cardiovascular events. The key therapeutic and endpoints and the requirements for FDA approval are improvement in MASH without worsening fibrosis. Now you may ask the question, why is it written that way? Because as you get to cirrhosis, you may see an improvement in steatosis. You may even see an improvement in inflammation because you're losing liver cells. And so as a result, it would be a false sense of efficacy. So you want to see the improvement in MASH without the only improvement is because the patient has already gone to cirrhosis. You also want to see, and the FDA requires it, that you see an improvement in fibrosis without worsening of MASH. Again, for the same reason. We want to see that improvement. Now, typically, the improvement in MASH, the first one, is now considered resolution of MASH, complete improvement of MASH. It's not really resolution, it's remission, complete remission of MASH without worsening of fibrosis. The improvement in fibrosis is one stage. If you start at F3, go to F2. If you start at F2, go to F1. So those are the specific criteria that are used by the FDA, and we would typically use them in clinical trials generally. Decrease in fat liver content of greater than 30% is the best early predictor. However, there are drugs for obesity that are in late-stage development that can go above 70%. We think that since 30% has been demonstrated to be the best predictor, if you get more than 70%, you'd have an even better prediction of improvement, but that hasn't been done yet. We don't know the answer to that. And in fact, you can see almost 100% improvement with drugs that have both GLP-1 and glucagon agonist activity. We've seen up to 100% decrease or improvement, normalization of liver fat. The mechanistic targets of emerging MASH therapies, thyroid hormone receptor beta is the target for resmetirom. The activation stimulates liver mitochondrial activity and lipolysis directly. The GLP-1 receptor agonist we've already talked about extensively. The activation promotes lipolysis broadly, stimulates anti-inflammatory effects, we think directly as well as indirectly, and induces insulin secretion through its incretin action. The glucagon receptor is the newest guy on the block here. The receptor is highly expressed in the liver. Activation clearly causes lipolysis. In animal models, it causes increased energy expenditure, but that has not been shown. It hasn't been shown or refuted for humans yet, so those studies are still pending. The FGF21 receptor, which is a group of drugs called fermins, F-E-R-M-I-N is the end of all those drug names, and the FGF receptor does have some anti-obesity activity, but it also has even more profound anti-MASH activity. And so you can see the effects there, similar effects. Now, if we look at some of the data, here's the Maestro trial from resmetirom. You can see that resolution of MASH with no worsening fibrosis is substantially greater with the medication at 2 different doses shown here than placebo, but you don't see complete resolution. You don't see 100% of people resolving. So there is quite a bit of variability, but the 30% that you're seeing here on the left is significant enough to engender approval by the FDA and use by us in clinical practice. With respect to the improvement in fibrosis, it's a little bit less dramatic because there's variability in biopsies, and so you can see here that 14% of people see an improvement. That may be one-day improvement. If you did 2 biopsies a day apart, you'd see some number of people having less fibrosis because fibrosis is very spotty across the liver. So you can see that, but again, we're not talking about a cure here. We're talking about a substantial improvement over what we could do before. Same thing is true with semaglutide. This is the Essence trial part 1 that I already talked about. Again, with respect to the resolution of MASH, without worsening fibrosis, it's about a little over 60%, and you can see the difference between the reduction in liver fibrosis with the drug versus placebo, again, for the same considerations that I just talked about. There are other non-invasive tests like enhanced liver fibrosis score. It's a marker, and you can see that semaglutide improved that score. It's not used routinely in clinical practice in the United States. It's more used in Europe, but that is a strong marker of improved MASH. And of course, liver stiffness also improves, consistent with the improvement in fibrosis. So here's a table that, here's when you can take your cameras out if you haven't already, showing the drugs that we have, that the 2 approved drugs, what their mechanism of action is, and what some of the other drugs. And when we talk about the investigational drugs, there is every reason to believe, based on the early data that we have, that tirzepatide will be an effective agent, but it hasn't been proven yet. Retatrutide, all we know about retatrutide, and I'll show you the data in a second, is that it clears the liver fat much greater than any of the other drugs that we've seen. Very similar to survodutide in that regard. Mazdutide is a drug that's being developed for treatment, for use for obesity, and has the potential for use for fatty liver disease or MASH in China only. That's the only place it's being developed. And pegozafermin is one of those FGF21 fermins that I talked about, along with efruxifermin, that are the furthest along in clinical development. So if we look at tirzepatide, this is a Synergy NASH trial. You can see that the outcomes look pretty similar to what we've seen with the very dramatic improvement in or resolution of MASH, and perhaps, although this is a small trial of only 190, phase 2 trial of 190 adults, it might be slightly better than the other drugs that you've just seen the data for. We have to wait for the phase 3 to really know that answer. And the reduction of liver fat is around 50%. What you can see here with survodutide, that the reduction in liver fat in the middle is getting close to 70% here. The MASH improvement in the phase 2 trial is quite substantial, and the fibrosis improvement is similar to the other drugs that I've already shown you data for. And then finally, with retatrutide, we don't really have MASH assessment yet, but we do have the relative liver fat change. At week 24, it's already down by 80%, way faster than the overall decrease in fat in adipose tissue, which is still going on at 48 weeks. And if you look at the percentage of people receiving retatrutide who achieved a normal liver fat, essentially nothing extra in the liver as far as fat goes, it approaches 90% at week 24, and it gets to 90% at 12 milligram dosing at week 48. Questions?
If the patients qualify for resmetirom based on elastography, do you need to do a liver biopsy to get insurance approval to pay for the drug before treatment and then 1 year after that? Or what is the protocol to see improvement?
So you don't, I mean, obviously it's going to depend on the insurance, but in general, no. In general, if you meet the criteria, we are moving very quickly away from, even surprise for me as a hepatologist, it's surprising how fast we're moving away from liver biopsy. These criteria are considered adequate. There are newer criteria, non-invasive testing, including MR-based imaging, CT1 imaging, and the like. And some of those may ultimately become, there are multiple different ones, but they may become standards that are even more specific and sensitive. But for the moment, most insurance will accept non-invasive tests.
I'm an endocrinologist. I work in primary care, preventative endocrinology. So in this case, I would decide to treat. However, if for some reason the decision is made to stop treatment, is there an attenuated effect, or is there a loss of effect? And after how many years do we see either? of that?
I'll start there by saying we don't have any data. We just simply don't know. We would guess that the known increase in weight, known increase in metabolic dysfunction measured in a variety of ways would probably predispose to worsening of the liver disease. But there's the timing of that, how fast it is there a rebound effect? We don't know any of those things. So right now, I would say that if somebody has at-risk MASH, which means F2, F3 MASH, I would strongly recommend that patient stay on the medication, and even more strongly than I might say it for obesity, where they have a little more agency to decide how much weight they want to lose, and et cetera, et cetera. But access is still a problem, and so access doesn't become less of a problem in this situation.
Yeah, thank you.
If regarding treatment, if we don't take into account the cardiovascular risk factors, so for example, the patient has no cardio risk factors, in deciding resmetirom and semaglutide, apart from BMI, is there any other factor? Because regarding BMI, what I see the problem in my patients is that it cannot differentiate between lean muscle mass and the fat mass. So how to decide that my candidate is good for semaglutide instead of resmetirom? Because if I give you a scenario, for example, I'm 6'3", I weight 110 kg, my waist is 54, my chest is 34, my BMI is 40. With the same scenario, my waist is 28, my chest is 54, my BMI is again 40. So, but there is a hell of a difference in that. So how to decide whether to go for semaglutide and resmetirom if cardiovascular factor is not there?
I think there are a lot of ways to partition that out. I think it's important to acknowledge that it's not GLP-1 or bust. I think this is kind of the environment I think many of us feel that we're practicing in. There will be people for whom these are not appropriate treatments or who are not tolerating treatments, and I think it's important to make sure that we don't just consign them to having failed treatment and, well, we'll just focus in on lifestyle again. I think resmetirom is a good evidence-based therapy. What I would kind of push back is, what I'm hearing you say is, in the absence of cardiovascular risk factors, I think we convincingly put data forward that even if traditional risk factors are not there, the hard outcomes and endpoints with regards to end organ damage and disease through a shared pathophysiology are there, even if they're not being detected through rudimentary ways we do this in clinical practice. And so I would say focusing in on kind of a holistic approach to the disease, acknowledging that there's inherent cardiometabolic risk beyond the liver as kind of the starting point is really important. So hopefully that kind of addresses the question of, is resmetirom still a treatment? Yes, it is, and I think it's up to kind of working out what are the actual goals there. We may say that someone has a lower cardiometabolic risk based on an absence of risk factors or inherent kind of laboratory red flags, but they're still at inherently higher risk.
I think 1, 2.
Seems like mechanistically, semaglutide and resmetirom could complement each other. So if the cost is not an issue, is there value in use both at the same time? Just report if a patient is really desperate to kind of lower their fibrosis and MASLD.
Yeah, this is a great question, and I think that may apply to the most severe advanced F3 or F4 cirrhosis as we learn more. There is a great deal of discussion about combining. Obviously, the expenses right now is an issue, but already there are companies that are combining the FGF21s with the GLP-1s, and of course we have GLP-1 glucagon combinations already as single agents. So I think that for people who are at the very highest risk, it may well be that we use combinations, but nobody's recommending combinations as a start at this point in time. And we don't know the subgroups and we don't know the cost effectiveness, but for all those reasons, that just means more research needs to get done. But by no means are we saying that this is A versus B. It could be A plus B in the future.
So you mentioned that the follow-up is with the elastography, right? What happens if it's not available? would you do it with ALT and AST? And also, what happens if you have a high score in your FIB4? I believe in one of your slides it says like directly treat the patient. So how do you do the follow-up in those cases?
So if I understand, what we would do if FibroScan is not available, is it sufficient to follow transaminase levels?
Yes.
Yeah, and I think that's problematic because of the sensitivity and the specificity of these. I think really you need a different kind of risk stratification that usually involves advanced imaging modalities, be it VCTE or MR. If you don't have FibroScan available, the likelihood that you'll have ELF or other testing is probably low, but these are things to be considered if they are available as a different way to risk stratify. But using AST, ALT alone in FIB4 is not sufficient, nor is it sufficient to follow people's course and trajectory, because as Dr. Kaplan says, as liver mass or liver cells diminish, the capacity to release transaminases into the circulation goes down too, and so you're going to get a lot of different answers that may be misleading.
I will say that there are some data that suggests that even if you have a normal, see, AST and ALT are not good screening tests. But if you have even a normal AST and ALT, the percentage going down, normal to normal, but it's still going down, over time is a good predictor. So not as good as the other tests that we have, but it's a decent predictor. So I want to differentiate the use of those tests for following versus the use of those tests for screening. Not a good screening test because so many people don't have normal, but once you are following it, you can use that. I would argue it's not nearly as good as the tests that we described, certainly not nearly as good as elastography, and really not as good as FIB4. But FIB4, remember, is using the AST and ALT as major components. So in the absence of anything else, follow it. But hopefully, if you've got somebody who really needs therapy and has got advancing MASH, you ought to be doing more if you have any access. I'd rather have no access to the following and get the patient treated than not treat the patient, because you're not going to harm the patient. You have other indications for treating the patient with the drugs. So don't be scared of it. But on the other hand, it would be better to do, as Jamie said, it would be better to use the better tools.
As we wrap up part 2, I want to highlight the major takeaways from this section. First, MASH is common, under-recognized, and characterized by ongoing hepatic inflammation and injury. Cardiovascular disease continues to be the leading cause of death in this population, reinforcing the need for an integrated cardiometabolic approach to care. FIB4 is one of our most practical and accessible first-line tools for identifying patients at risk for advanced fibrosis. Its simplicity allows clinicians across multiple specialties to incorporate MASH screening into routine practice. On the therapeutic side, we now have a rapidly expanding pipeline of agents that target multiple metabolic hormone pathways, including thyroid hormone receptor beta, GLP-1, GIP, glucagon, and FGF21. A consistent theme across these treatments is that activation of glucagon receptors in the liver appears to preferentially enhance fat clearance, which may be a key mechanism of benefit. We also reviewed the primary clinical trial endpoints used in emerging MASH pharmacotherapies. Resolution of steatohepatitis with no worsening of liver fibrosis. This endpoint reflects a shift toward halting inflammation while preserving or improving fibrosis. Finally, across phase 2 and phase 3 trials, a reduction in liver fat of at least 30% has emerged as one of the strongest early predictors of improvements in MASH and fibrosis. This has been observed with semaglutide, tirzepatide, survodutide, and retatrutide, suggesting a unifying therapeutic principle. This concludes the key takeaways for part 2. I'll now hand it back to Rachel to close out the program.
Thank you for watching. Please click the Claim Credit button to claim your credit. Please complete the evaluation as your thoughts and comments help us develop future education. And be on the lookout for our 30-day survey. Thank you, and we'll see you soon.